And I'll kick us off. Basically, what we're going to do today is tell a story about our practice development of our practice framework. But we're going to focus the story on our collaborative development of our treatment plan and the development of goals and interventions. So our agenda, like I said, first of all, I'm remiss by welcoming everyone to, we're in beautiful, now sunny Baltimore, Maryland. So I'm going to review some of the core components of the trauma integrated TFC model, and then Kristen's going to tell the story about the development and the components of the mapping, the CANS ARC mapping and the reporting, and then to demonstrate some of our attachment regulation competency ARC treatment goals. And then Nate's going to talk with us about his experience of collaborating, and it's more about software. Our collaboration with advanced metrics goes well beyond software collaboration. I want to learn about that wonderful collaboration. So next slide. So for those, I direct the treatment foster care at Kenny Krieger Institute in Baltimore, Maryland, like I said. For those that are not familiar with treatment foster care, it is a family-based service delivery approach, providing individual treatment to children, youth, and their families. Now, the treatment is delivered through integrated constellation of services, and this is key, that the interventions and supports are provided by the treatment parents. And the treatment parents are supported, supervised, and trained by qualified program staff. In our program, they're clinical social workers. We call them master's level social workers licensed. So the demographics, just to let you know a little bit about our program, demographics. Next slide. Basically, we're largely male, 2/3 of our program nearly. African American, 60%, which is in line with the demographics of Baltimore, Maryland, the city. And then we have a wide range of ages. We have an adult program, and then we have the diagnoses are, basically we put them into 3 categories, but they're these are just the top ones: mental health diagnoses, medically complex, and then the developmental disorders. So just to give you a snapshot of who we are. The model, the trauma integration model, I'm not going to go into details. I'm just getting us started for the real champion, which is Kristen. Just to give you the background of our model, the trauma integrated TFC model. And another reason I'm not going to go into details is you can find that on the California Evidence-Based Clearinghouse. But basically, it's focused the values, the TCOM values, the principles, and the integration of like most treatment foster care, integration of behavioral health, systems of care, principles with child welfare, safety, permanency, well-being. A key component is the integration of staff and parent training, which is lockstep to the same, and the transfer learning. What the transfer learning is the in-home implementation of the learning for the treatment foster parent as they're intervening with the child, and then are supporting that through our clinical social worker supervision and consultation and coaching. And we'll talk a minute about our focus of change, which I think is critical. And then, like the diagnosis pointed out, we're focusing on treating the complex trauma. We're using an attachment regulation competency model. We feel we have best practices in addressing developmental disorders. Our organization, Kenny Krieger, is a university affiliated program and a center of excellence for developmental disabilities. And we address medically fragile, or we call complex medical conditions. And our connection as a university with Johns Hopkins, we're allowed to, we have some really nice resources there. The focus of change is really critical. It's the relationship between the treatment parent and the child and the child's birth family. That relationship is facilitated by the clinical social worker in collaboration with the treatment parent. The clinical social worker also, in collaboration with the treatment team, develops and implements the treatment plan, goals, which are informed by the CANS and the CANS ARC mapping, and Kristen will get to that in her piece. Our focus, just as a background, our focus of change was really developed through, in my experience and a mentor of mine's experience in child welfare, and our training at the Child Guidance Clinic in Philadelphia. It's really focused on developing the best practitioner. And in this case, when I say practitioner, I'm not just talking clinical social worker, I'm also talking treatment parent. The principle in this focus of change is in order for the child to change, everyone in the focus of change needs to be also able and be willing to change. So that includes the child's family, the treatment parent, and the clinical social worker. So there's been a lot of focus recently, a lot of focus in evidence-based practice, but more recently in child welfare with the family first. Next slide. This was a slide I was going to conclude, but I thought we would, because this is some work we've been doing, collaboration with Steve Shimshock and Brian Shore, who I think is on the call, and just part of the paper we're developing. It just gives you a snapshot of some of the change over time, 2 points in time, 3 points in time over a year, 2 points in time, I'm sorry, over a year. And when you look at the comparison of all total all TANs items, you see the reduction, and these are 3 classes. This is part of a latent class analysis, and with the top, I think it's purple, are the kids that are primarily behavioral, emotional, with the next being developmental, medical, and we have a third blue line, which is a low need group. So that gives you some understanding in terms of progress. But our collaboration is really continuing because, like I said, we're focusing on developing the best practice and the best practitioner. And so we're going to continue that collaboration with Steve and Brian in the use of predictive analytics and facilitate collaborative inquiry. So we'll be integrating that into some of the work we're doing at a later point. So that's my piece. Kristen and Nate will continue telling the story, the collaboration of the data-driven treatment plan and goals and interventions.
Okay, thanks, Paul. Okay, Paul touched on some things related to the future of our program, but I'm going to bring us way back in time a bit. Our program's been using the CANs probably for over a decade. I think we were thinking around 2008. Over time, we really began to focus on meaningful use of the tool and how to use it to develop treatment goals and a comprehensive treatment plan that meets the needs of the children that we serve in our program. So we also discovered that there are various versions of the CANs that existed, recognizing that states and other programs across the nation were developing their own version. So we decided to get on board and develop our own as well so that we could capture the populations of youth that we serve. We named it the Integrated CANs because it integrates the general domains of the CANs, like life domain functioning, child strengths, etc., with domains that speak to trauma, developmental needs of the youth at birth and over time, items specific to transition age youth entering adulthood and preparing to exit the foster care system, and for those with medical issues, a medical domain to help us capture the complexity, family stress, and continuity of care of the youth that the youth receive. And then while we were developing the integrated CANs, we also wanted to begin paying special attention to the caregiver and expanding the use of our caregiver items. So based on what Paul touched on before as an essential part of our program model, we identify the treatment parents as the focus of change. We recognize that it's their characteristics, their abilities and skill sets that really promote the progress in the youth that we serve. So we collaboratively work with the caregivers to address their needs and strengths. So we can determine things like their knowledge of parenting and child development, their use of positive connections and concrete supports in times of need, their ability to nurture social and emotional competence in children, their personal resilience, and of course, their commitment to the youth's permanency plans. And as youth prepare for their permanency plans, clinicians are also encouraged to work with adoptive resources, biological family, fictive kin, whoever's going to be the placement resource, to do the CANs with them, to identify their strengths and needs, so that we can best support and train them as the youth prepare to transition to their homes. So ultimately, we created quite the comprehensive CANs for our program. It contains a total of 152 items and 5 additional subdomains. Yeah, you can stay there right there for a moment. We developed an integrated CANs manual that incorporates specific indicators and descriptors for scoring 0 to 3. And it also serves as an interviewing tool. So for each item, there are several questions that can promote conversation to create hopefully consensus around decision-making and scoring, ultimately to support the communimetrics function of the tools. So you can skip to the next slide. So with the help of Nate and our collaboration with Advanced Metrics, we were able to add our version of the CANs into their system, the Children's Outcome Management Center, or what we consider the KidNet system. It's incredibly user-friendly and allows us to complete the CANs live with families. And in our current climate, we've really been able to use it virtually with ease. So as you can see, there's my picture, kind of displays what the screen would look like if you were doing, the CANs with your clients and families. Everyone can clearly see the items and the scores. But even better, you can skip to the next page or the next slide. Yeah. If you click on a certain item, the scoring criteria shows up, as well as the corresponding interviewing questions. So an example displayed was, for this particular item, was ability to communicate, which is a caregiver item. And there's questions posed, such as, is the caregiver able to express their thoughts, their feelings and beliefs regarding parenting? How effectively can the caregiver communicate about these issues regarding the family and the child? So the clinician can reframe these questions to directly offer them to the caregiver and ask them, how comfortable do you feel? How capable do you feel as the caregiver expressing your thoughts and feelings and beliefs? And if anything, what seems to be impacting your abilities? Is there anything positively impacting or negatively impacting? Then, of course, a discussion can be had, and ideally a consensus can be made on the scoring. But moreover, depending on the scores, if there's like a 2 or a 3, we would likely begin problem-solving ways to address this need and develop a treatment goal around that. But on the flip side, I want to mention that, if they are scoring 0s and 1s, we want to acknowledge that as well as a strength and ability that we can use to incorporate in other treatment areas. Okay, you can skip to the next one. So the CANS assessment, as you all know, is helpful when trying to identify what exactly needs to be addressed. But there is another component of our model that Paul also touched on that helps us understand perhaps why and how to address these various items and areas of need. And that is the ARC. It was developed by Christyn Kinnenberg and Margaret Blaustein. The ARC stands for Attachment, Regulation, and Competency. It is a framework which is flexible and components-based. It's an intervention developed for children and adolescents who've experienced complex trauma, along with their caregiving systems. So before we get into the actual structure of the framework, I'd like to mention that the ARC has 4 real key areas of study: child development, traumatic stress, attachment, and risk and resilience. So for the most part, the children that we serve are profoundly impacted by traumatic stress, and they've experienced at least 1 or more attachment disruptions. And we know that these issues do have negative impacts on child development and competencies across developmental stages. But we also know that when the issues are addressed, risk can be reduced and resilient outcomes can be achieved. So this framework means a lot to us. It's used with individual case level work, but it's also been embedded in our program culture as we strive to provide trauma-informed care. We've been working with Margaret, but mostly Christine, for many years through monthly case consultations, collaborating on ways to best understand the framework and how to utilize it in our practice. We've been with them as they've modified the framework over the years. And for those of you who do want to look into it, the framework was originally introduced as a pyramid. It's kind of been like restructured or renovated into this house. Again, it consists of the 3 primary domains: attachment, regulation, competency, and within the 3 domains are corresponding building blocks. So for attachment, it's all about focus on caregiver affect management, attunement of the child, and providing consistent and effective responses. There's a whole section on regulation, teaching affect identification and modulation with the children. And then competency incorporates information about executive functions, how to develop self-development and identity, relational connection. There are also 3 foundation blocks, and they are identified in the yellow or gold part of the house. And they were added when the house was built as an emphasis to ensure that you are using engagement, psychoed, and routines and rhythms within all the other work within the building blocks of the house. And then kind of to tie it all together is the top of the house is called trauma experience integration. And that focuses on exploring the ways that children who are exposed to more complex trauma may process traumatic experiences. So for this, it's about, helping youth identify and reflect on fragmented self states and functioning, as well as ways to support their narrating and processing of specific events in their lives. So I highly recommend Margaret and Christine's book. It's called Treating Traumatic Stress in Children and Adolescents. It's in its second edition, and it includes a great deal of worksheets and tools and interventions to use with youth and families. So next slide. So again, to kind of recap, the CANS tells us what, and the ARC tells us hopefully why and how to address youth and caregiver needs, especially as it relates to complex trauma. But fortunately for us, we're doing the CANS, we're doing the ARC. There was a crosswalk that was developed between the CANS. It was the Illinois CANS at the time, and the ARC developers. They worked with Cassie Kissel out of Northwestern University to do this. And what it is, it's a crosswalk that pairs various CANS items with the ARC building blocks. And many of the items are then considered and weighted to be either primarily related to a building block or maybe just relevant to a building block. So once we input all of our CANS scores into the KidNet system, Advanced Metrics has allowed us to add mapping capabilities and graphing into our software system to provide depictions of our clients' data over time. So you can show that one. So here's an example of some of the graphs that are produced from our data. The larger graph displays the CANS items that are linked to the ARC building block of caregiver affect management, which again is part of the attachment domain. So Nate, I don't know if you can, but can you make it just a bit bigger so maybe people can see more closely?
I can, but I may run the risk of turning off everything. So
yeah, we don't want that to happen. All right. So I can basically explain. So on the left side, it'll just indicate which building block it's referencing. And so in this case, it's caregiver affect management. The two words under that are primary and relevant. And then all of the items that are listed from top to bottom are CANS items. So for caregiver affect management, some of the CANS items that are primarily related include understanding of impact of own behavior on children, substance abuse, natural supports. No, can you go back again? I'm sorry. And then as you see at the bottom of the graph, there's the scoring 0 to 3, and then you can see kind of the multiple color bars that spread across the page, and that captures CANS scores over time. So each color, of course, indicates a specific time period. So using the graphs, we're able to determine and display to our families, and again, we can do this virtually, what items we need to keep our eyes on, what items are actionable and could be addressed through treatment planning. And of course, the items that require immediate or emergent need. We can also show clients and families how the items are connected to the various building blocks, and they can see the scores over time. They can see patterns of scores over time, progress, regression, et cetera. So you can't really see it in the smaller graph, but there are other ways to depict the data as well through the mapping, and we can see which domains such as attachment, regulation, or competency has the most actionable items, which domains have the least amount of need or the most progress as well. Okay, you can go to the next slide. So basically, this is just a general understanding of how the mapping works. If you're thinking about a particular case and kind of want to look at it backwards, the orange bars are the two CANS items that we found to be actionable, say in this case, which is impact of own behavior on children and ability to communicate. And they're primarily related to caregiver affect management under the attachment domain. So our next step then becomes, what treatment goals can be established here? And then in doing so, what we want to do is we want to refer back to our knowledge of the ARC to help us come up with why and potentially how to make progress in these areas. So you can go to the next one. So this slide's kind of busy, but I want to give you guys a little bit of an understanding of what caregiver affect management is. I'm going to read the overarching goal, and that's to support the child. Support the child's caregiving adults in understanding, managing, and coping with their own emotional responses so that they're better able to support the children in their care. So in order to do that, The TFC workers really need to devise coaching strategies, training of sub-skills that are important to this building block. So maybe that's starting with the foundation principles related to psychoeducation around trauma and resilience. Maybe that's normalizing and validating the caregiver experience. It could be helping the caregivers develop self-monitoring strategies. We also really want to work on the caregivers' affect regulation skills, and even want to emphasize, how important it is for them to be able to manage themselves so that they can also, teach and potentially co-regulate with the children in their care. Under this goal, we also want to make sure that each of our caregivers have self-care plans and that they're able to leverage available and supportive resources. So basically, whatever's most needed or relevant to the individual cases related to the needs of the youth and the families. So if we go back to our hypothetical case example again with this particular family, we want to focus on strategies specific to the two actionable items that were identified. And again, that's communication and impact. So in this case, this is a real life case for me. I kind of pulled these goals. The caregivers agreed to develop and utilize their self-care plan, and that's to include both in the moment and long-term strategies. And that is, accessing one another for help and participating in their program support group. Another example, noted here on the slide is to build active appraisal skills by stepping out of a difficult situation, becoming aware of their own emotions, and then re-engaging the child once they have a more helpful and regulated response. So upon developing these goals, we also discuss specific steps to achieving them. So we want to make sure, that we have developed a self-care plan, that we're able to test it out, and we have a way to kind of track progress over time. Does it need to be changed and adapted? Is it working? And our programs really started to make a more valiant effort towards creating goals that are SMART. So of course, like specific, measurable, attainable, relevant, and time-based. And then these SMART goals are then added to our quarterly treatment plans. So you can go to the next slide. So going back to our work with advanced metrics, we developed a treatment plan that allows us to easily add our treatment goals for each applicable ARC building block for each case. And the treatment plan provides us a space to add both long and short-term goals associated with trauma-informed interventions. We complete our treatment plans quarterly and are able to track the progress and applicability of our goals and steps every 3 months. But we're also able to capture and document the progress on a more frequent basis as well. And that's with the use of our clinical case notes. You can go to the next slide. So this is an example of our case note. It looks quite similar to our treatment plan. It mimics its format and content. The case note also helps us track progress in data, assessment, and helps us plan for our future sessions. The case note keeps everything streamlined and consistent. We can write notes in session with the help of the client and the family. We can update our case notes and treatment plans in real time and virtually with the collaboration of the treatment team members. This kind of helps everybody stay on the same page. Everybody knows exactly what we're working on and how we're measuring things and how we're, defining progress over time. You can go to the last slide for me. So beyond the clinical data, Nate and his team have really helped us add additional components to our treatment plan, more than just the trauma-informed treatment processes. So, we thought about what's important for, our families in our program to track. So we made sure that, we have all the medical needs of the children documented in our treatment plan. So that's everything from medications and diagnoses to tracking each and every provider's contact information, appointments, current and future. We track all the children's educational needs, receipt of report cards, if we have the 504 plan or IEP. The system helps us capture data specific to the children's permanency plans and legal history. How many foster care placements have they had? Does all the team members approve of the permanency plans? And what do we believe to be their estimated discharge dates? And then we have goals specific to our transition age youth who are preparing to exit foster care. And then we have another assessment that helps us develop these goals, and it's called the Transition Planning Assessment, and it incorporates parts of the ANSA. So essentially, Advanced Metrics has helped us really develop a pretty robust and comprehensive treatment plan and case note where various elements of our program model can be integrated and utilized effectively in a streamlined way that helps us as clinicians properly identify appropriate treatment goals using the CANs and, based on the needs and strengths of our clients, and a way to also utilize the ARC to develop trauma-informed treatment strategies. And then I do want to mention, like, the ability to use the tools virtually has been incredibly valuable. It's helped us stay connected to everyone, including, other team members, as we do our best to partner with them and collaborate towards better outcomes for the future of our youth and families that we serve. And I'll just end by saying this process hasn't come without its challenges. And we've worked with Advanced Metrics for, a couple of years, creating and tweaking this along the way. But I'll give it to Nate to talk more about, what that entails. So.
That is awesome. Well, thank you for that. Yeah, before everybody jumped on, Kristen, make sure she prefaced that she was going to talk about the successes, and then I was going to come in and talk about the challenges. So it works out well. But yeah, thank you for kind of allowing me to come and talk a little bit about this. And as Paul had said in the very beginning, when we were kicking this off, that the relationship between Kennedy Krieger and Advanced Metrics is more than just software. And I think that really holds true and has led to a lot of the successes that we've been able to accomplish over the last few years. Just kind of a very off topic story is I still remember this was one of the interns that was working, and I think actually is still working at Kennedy Krieger. We were sitting in a staff meeting, and I was there and participating in the meeting and doing everything. And she was curious as to how long I had worked at Kennedy Krieger. And I was like, oh, I don't work at Kennedy Krieger. I work for Advanced Metrics. I work for the software company. And because of the partnership that was created, it was very much this integration. All right. So as I'm talking about some of this collaboration, it really is important to note that. Also, now taking a look at this slide, when we're looking at this iterative collaboration process, you'll notice that the software development is 4 down on the slide. And then there's a reason for that, because so much went into the planning and the understanding and the building of that relationship before we ever got into the concept of looking at and deploying software. So that first bullet point, you're identifying the need for a treatment plan and a case note that complemented a clinical framework. So this was essential. And I know Kristen had mentioned, she said, oh, thanks Nate and his team at Advanced Metrics, but I'm going to put this back on the clinicians. Kennedy Krieger had set up a framework and a structure where their input was valuable, it was asked for, it was wanted. There were clinicians and interns and supervisors that really informed this process from day one to even now, when we're kind of in the later stages. And if there was a bulletin board behind Kristen that talked about version 2.0 of the treatment plan, where we're already thinking about what some of the enhancements could be made. But they identified this need for a treatment plan in a case note that it was more than just collecting data. It really focused on what were the clinical needs of the individual, of the children and families that they were serving, and what was a way that they could capture those needs that would help inform the reporting process and the outcomes and all of those different things. So then we got together for these initial requirements gatherings. And these were great. So it was like, they started off where it'd be in a room full of clinicians and people from my team, and we would have binders, and we would say like, okay, I remember the very first meeting, this is what a paper binder looks like. And we went through all of those different things and really got a sense as to what these clinicians do day to day. And not only what the clinicians are doing day to day, but what the data entry folks were doing day to day and what each member of that team was doing. So we took all of that information and then really broken it down into individual work groups. some focusing on the clinical side, some focusing on workflow, some focusing on making sure that we're not missing any of the case management responsibilities or case management pieces. So this section of it's interesting. It's one line item, but this took a long time, and we're actually still going through this process because as things change, as we recognize maybe the needs of families change, maybe the requirements from the state change or the feds change, and so as those things change, we're making sure that we are changing and adapting and growing with them. The next bullet point really is the workflow. This is essential because oftentimes, and even going back when I was a clinician, and I hate to use that, like, date myself, but when I was a clinician, we knew what we knew, and we knew how we did our day-to-day job. But when someone would ask, like, how do you do your job? It's not always the easiest to articulate that. You were very comfortable in how you did it, when you wrote your notes, when you met with families, what you wrote, all of those different things. But what this did was it really gave us an opportunity to meet with individual clinicians, to understand their workflow and how they applied their knowledge to supporting the families and what that looked like. So we really were able to get into the weeds and understand what exactly the clinicians and the supervisors were doing on a day-to-day basis, because that's really going to inform the process. Anytime you're developing or anytime you're deploying software, if you don't understand the workflow of what actually is being done, then what you're doing is you're deploying something and you're focusing on changing the workflow or changing all of those things, when in reality, we wanted to do something that supported the clinician's workflow. And then the software development, and I think the next slide will talk about some of the challenges, but there was a number of challenges when you're talking about software development and the implementation, but no challenges that couldn't be overcome, right? So that's why you had those first 3 bullet points here as we're building that relationship. So when you're building that relationship, it makes those challenges just necessary or next steps, not necessarily things that you can't overcome. And then the testing and integration, which is a key point, key piece in this kind of machine that we have created. And the important part here is the testing. The testing and integration was done on a kind of very iterative basis, where we allowed clinicians were able to get in and say, yes, I like this. No, I don't like this. Or yes, this works for me. Or why does it function this way? So they were able to have a voice in this process and ask questions. So we didn't wait until it was time to go live or deploy everything to get feedback. You really started that feedback loop right away, so that before it went live, the clinicians had already had an opportunity to see what they were going to be using, which really helped inform and the implementation or the kickoff, because they'd already seen and had an opportunity to use the software. So let me go to this next slide, and I am going to pause. I'm just going to move everybody's picture to the side so I can see everything. Sorry about that. So lessons learned from this collaboration. Well, the first one is dedicate time and adequate human resources. I think when we go into something like this, when you're developing something new, oftentimes we really don't recognize how much time is going to take to be able to get exactly what you're looking for. I think Kristen and I have had many conversations about what it looks like to build a new CANS or have a treatment plan or the case note, and what that actually looks like, and how we can get all of the information from the clinician. So it's really important to recognize that when you embark on something like this, you want to be able to have that dedicated time and resources available so that you really can make this a priority. And I will say, even this is a lesson learned, but as we went through this process, Kennedy Krieger was exceptionally well at allowing clinicians the opportunity to be involved in this process, and make their feel as though their voices were heard, which was really exciting. So some of these lessons learned are not necessarily things they may have been addressed through the process. They were learned very early on, and we were able to kind of make those adjustments. Like you said, prioritize development rather than make it an extra responsibility. Very important. Have realistic expectations. I think having realistic expectations with anything in this world is really important. But for this, it's very important. Well, we talk a lot about these things like nice to haves versus I have tos versus I wants and different things. And being able to kind of really break down the workflow and understand exactly what is needed and how that will look is very important. So having realistic expectations about the process, recognizing that you may not get it right the first time, you may not get it right the second time, but part of the process and that collaborative, those kind of lessons learned in that collaboration is each time you move and each time you do something, you're learning from it. And you're moving on to the next. And each time you are learning from, I call them mistakes, but they're really not mistakes. You're just learning from the choices you make, and then you make them differently at the next stage. And then I think the last really important bullet here is this commitment to the end goal. It's having open and honest dialogue with the team about what you are trying to accomplish. And I think that goes back to the whole premise of what we're trying to do here. And that was involve every member of the team, that they had a voice, that they felt that they were a part of it. So when you're rolling out a treatment plan, or you're rolling out a case note, or you're rolling out changes to the assessments or anything like that, they feel as though they were a part of that process, whether they were a part of the development or the implementation, or simply were just brought in to be able to review something. Everybody was brought along. There were no surprises. So it's really important to have that honest discussion and open dialogue with every member of the team, because when you make changes like this, it does affect how they do their job, and it affects what they do. Also embrace each team member and their expertise. That's the great thing about working in the teams and this collaboration, is being able to recognize that every single person brings something new or different to the table. Where you have some people that have this very creative and intuitive brain, and they're like, well, maybe we should put this button here, or maybe we should move this over here. And then there's others that have this incredible ability for like looking at the wording and saying, well, if you worded this sentence this way, it changes the entire feel of the page. So you're bringing all of these different skill sets and all of these great minds to the table and using their expertise. It's so important not to shut out anyone's voice or anyone's opinion as you are trying to kind of move forward and deploy something as innovative as Kennedy Krieger has done here. So sorry, somebody just popped up the admit. So let me. So
well, Nate, the one thing I'd say is, this has been a multi-year collaboration.
Absolutely.
From the very beginning, and getting buy-in to the system, getting buy-in to the cans has been a continual effort, and you've been helpful in doing that. So there's buy-in and sustaining buy-in, because I know when the system was really robust in the sense early on, in the sense that we were getting some really robust aggregate data, change over time. I mean, some really nice things. I know, but presenting that to staff, it was like, well, so what? What is that? And when I go into the home, so we get certain percentages change over time. And I think we were able to I think the Breakthrough Series collaborated with National Traumatic Stress Network. I think, Kristen, we got a lot more buy-in there, because I think people understood more how, and that really shifted my thinking, that in order to get the maintain buy-in, you've got to be able to create value added for the clinician. That was my big take home from the Breakthrough Series. And I think Kristen, being one of the champions, kind of ran with that with staff. We were already using the ARC mappings, working with Cassie's group. And so they were really bought into using that, but it wasn't part of the system. They went out of their way to use that, they had to download it in a whole separate piece. And I think that really, I think that allowed staff to gain some additional buy-in to the cans because, they were more concerned with the how and why, and improving practice. So I think that really was my aha moment, again, to say, look, for the sustained buy-in, you've got to be able to build this into the system. This has got to be the work. And it's got to be within the treatment plan. The treatment plan that they had was, no offense, but it really wasn't well, based on what staff was saying, it was not helpful as certainly this one. And then so I think that kind of took, that's how I see the evolution of what we were able to accomplish. Keeping in mind that this was only rolled out in January and, I think later than January, and we still there's some real lessons learned.
Well, one of the other, sorry, Paul, to cut you off. One of the other lessons learned, and I think this is a testament to what we've seen at Kennedy Krieger. So as Paul had said, when you're talking about this rollout in January, imagine these changes happening within your organization. You're rolling out a new version of the cans, right? You're rolling out a new treatment plan. You're rolling out a new contact note. And all of these different things are happening in the midst of everything that's going on in this world. And what you're seeing is that buy-in that Paul was talking about is you're seeing actually an increased use and an increased desire to get involved and to utilize those different resources. I will say when we're talking about the integrated cans, I know as I've sit on a lot of these sessions and I've been coming to this conference for I think about 6 years now, there are a number of different versions of the cans out there, right? And in some locations, some versions you have are 50 some odd items. In other areas, there are a lot more items on different versions of the cans. Every region's a little different. This integrated cans is really a very robust version of the cans, and you're bringing in a lot of different pieces on it. So there are a lot of items, okay? Even though there's a lot of items, what we're seeing is an increased desire to complete the cans and an increased desire to utilize that cans in their treatment planning process and in their work with the children and work with the families. So that speaks to that buy-in that happened well before January. It happened. It happened over the course of the last many years as you're working and stressing the importance of utilizing the tool and utilizing the data to help really drive those decisions. So when we rolled out this new version of the cans with more items, we get to the point where staff were just like, okay, and they ran with it, and they just really just adopted what Paul and Kristen and the team were trying to kind of bring to the table.
And I think they're grouped in a way that makes sense to the clinician as well. And the more that they get familiar with the language and the scoring, it becomes less, entailed and easier to complete. So regardless of the 152 items, I think people are completing the cans, I was surprised, a little bit more efficiently than I once, thought when we developed it. So it's been really good.
Absolutely.
Sorry, Paul, I didn't mean to cut you off. Were you going to say something?
No, and I think the next steps, I don't know if we have time for the questions, but, or there's next, we can talk about, we thought about doing next steps, but we didn't think there'd be time. But, any questions from people? There's quite a few people on the call.
This is always my favorite part of Zoom meetings. Like, who wants to go first?
Well, it's interesting. In reference to what you were saying earlier, I remember that story when Kristen came to me in the development of the integrated cans, and I said, well, let me look at it. And there was like, how many items are there now? 161.
152.
And 152. Well, we were only required to use the Maryland cans. Which was how many cans items is that? 80 or?
There was just shy of 80. Yeah.
Just shy of 80. I'm saying, what do you mean that staff are willing to? They're not going to want to do this, but they're recommending this because this is staff driven. And then lo and behold, like Nate's saying, they're actually using it, and it just speaks to the value added. And well, I think the effort in developing the product, so to speak, but also the value added. And what's really wonderful now, I hate to say this, but there's nothing wonderful about a pandemic, obviously. But in terms of using virtual, like Kristen referred to several times, the capacity to use this technology and virtually has really, because I know staff was very anxious about, well, how do you, because there's a shift in culture in terms of using technology. Do you take the laptop to, how do I do this? How do I take notes and, at the same time? And now the virtual pieces have forced us to do that, allowed us to do it, and it's forced us to do that. So the workflow has really, I think, and the capacity to invite multiple team members to the meetings has increased in terms of, because it's so much more accessible. And then using this in our case consultations and coaching, which we're doing more and more of, I think really lays the groundwork for the next steps, because as we start sharing some of the data from the work from Steve and Brian, in terms of the predictive analytics and those items that we're really doing well with, but more importantly, those items we aren't doing well with, especially at intake, it really kind of drives home, and we're creating a culture where through that discussion, it really it really fertilizes the soil for us to start talking about cases in relationship to the aggregate, which is the facilitated collaborative inquiry aspect.
And
so,
Paul, really quick.
That all together.
I was just going to say really quick, before we move into some of those next steps, there was a question that I just noticed in the chat.
Well, let me see.
And it is from, in San Bernardino, kind of the excitement about using the cans varies between locations. And then is there any variation between the clinical units in your agency? And if so, how do you address that?
Well, we're the only clinical, we're part of a large teaching facility. A rehab hospital is part of an academic institution. And we're also we're embedded within a large outpatient department that has a large outpatient department, the Center for Traumatic Stress. They do not use the cans. We're the only one using the cans in the institute, okay? And it's interesting in terms of some of the, we've gone from years ago, people are researchers, faculty saying, why are you doing this? You're never going to get the data you need to support your development of the program for evidence. Clinicians saying, well, it's too much, it's too hard. To, I think, Kristen, you tell me, I think we've kind of, I don't see other departments, other clinics that are providing any real-time data to their clinicians. So I think there's certainly a notice of that we have this real-time almost use of data meaningfully, where other clinical departments, and we have a very large outpatient, there's several outpatient departments. But one of the things they're struggling with is how are they providing real-time data to the clinician to support any meaningful measurement of change. So I think I don't think we'll change that culture, by the way, but I do think that there's more an acceptance. Now, in terms of other programs, I can't say, but so we're maybe fortunate that we have a small ancillary group here. So Tim,
and Paul, if I could expand upon that really quick, though, you are right about how you described everything. But Tim, I don't know if this is something helpful. Now, even if you look at that small kind of unit that is the treatment foster care program at Kennedy, if you look at that, though, there's different responsibilities and there's different skill sets of those clinicians, where you have some clinicians that are geared really working within children that the medically fragile, and then you have they're really working with children that MH. So you're getting this different grouping of individuals that are being served by the same program. And then in addition, the way it's set up, you have this case management function that each of the clinicians is responsible for in addition to the clinical work. So when we were talking about the case note and we were talking about the treatment plan, it really, and the CANs in general, it wasn't that we had to go beyond that department or the TFC program, but what we had to ensure that was happening is that we were taking the individual workloads of each of the clinicians in mind, where one clinician may say, well, that doesn't apply to me. Another clinician may say, well, that doesn't apply to the people that I work with. And then how do you then create excitement in that world?
Right.
So it's a little different. It's not like the blending of like two different units, but because of the diversity of the population they serve, it sometimes felt like that, because you were really trying to navigate that world and make sure, I want to use the word keep everybody happy, but make sure everybody had a voice. And where was the give and take with some of that?
Well, I think too, Nate, I think the issue for us, I can't speak to other clinical units, but to speaking for ourselves, I think certainly the implementation science in terms of the champion and trying to supporting the champion and creating the excitement. But I think key is that the issue I mentioned earlier, value added. What am I getting out of this as a clinician, as a supervisor? What's in the game for me? And I think that, and I think the only way to address, the best way to address that, maybe the only way, is to make the data meaningful and connected to their work. So they're meaningful work. They're making change. They're struggling with how to do that and managing change, and to give them information that says, hey, this is helpful, and this can be, and you can use it to measure. Like I remember earlier on saying, well, why are we using the cans? I know this stuff. And I said, well, that's good, and I'm glad you know it, but do you know what's going to happen in 3 months? So, kind of shut up and do it. But now it's like, no, they want to use the information. They want to gather the information. They want to do it collaboratively. Because they see I think they understand, you tell me, Kristen, the value of having buy-in, and then to be able to use the data in a way, the information in a way that they can say, oh, this helps me, going back to Kristen, this helps me with the caregiver, helps me with my treatment parent, to help them understand that they need to understand more about their own affect management, and it really, now I'm more of an ally with them, and I'm a team member with them, and creating that common language. So I don't know if that would, I don't know if that, again, answers the question in terms of the excitement, but I'll be honest with you, I think there has been, and certainly an ebb and flow, and I think we're flowing right now, but certainly, but I do think that this treatment, what I've seen with the treatment plan, has really been an opportunity to really sustain the buy-in, and so I think that, and we're going to have to keep the excitement going. That's the thing.
We've experienced a number of changes, in staff. So everybody needs to be trained on all the components as well. So they need to be trained on the CANs. They need to be trained on the ARC.
Right.
They need to understand the mapping. They need to be able to articulate how the mapping applies, to the clients and the families. They have to learn the software system. So, when we were developing all of this, we had a lot of staff that are really, engaged in the process. And then we have interns on board and, new staff members. So trying to keep up that, momentum, has been a challenge, but I think it's doable, and it allows us to, again, streamline our work and kind of put everything together. Now we have one document. We can say, everything's in here, this is what we're working on. And then we have that case.
It's less relying, no offense, but we can rely, can rely, Kristen, less on champions and more on the Fidelity based on the treatment plan. I think that this is, to me, is creating Fidelity. So it's always staff comes, staff goes, and when things change, you got to create the buy-in. Well, they're starting at a certain point. That is the treatment plan, and it gives us more of a focus. But again, it's meaningful to them. It's not something that's prior. You did the CANs and then you did the treatment plan. And then how do you why am I doing the CANs? It doesn't really help what I'm doing because I already know. And no, it's that integrative process, I think, is what's been most helpful, and I think has created, I don't know if it's you tell me whether it's excitement, but I do. Well, from my perspective, there's less complaints. So, any other questions? So, we're almost to time to the end here. So, any wise words, wisdom here, Mr. Lubold?
I don't know if you consider my words wise. But I will say this has been a fantastic collaboration, and Paul and I have I've had the opportunity to present with Kennedy Krieger over the years at a number of conferences, whether it was the TCOM Conference or FFTA or other places. And I think one of the important pieces that I'll leave here today is the concept of this ongoing connectivity and this ongoing, once you create that initial buy-in, right, it is so very important to never lose that momentum, right? It's so important to not lose that excitement. So it's creating a structure inside your organization that you're constantly asking questions and you're constantly getting feedback, and that we talk about this, using the CANs as creating that common language between clinicians and families. But we also want to be able to create this common language and use that to be able to talk amongst ourselves as clinicians and with supervisors and at the agency level, and with people like me that stop in once a week or once a month to be able to help support the programs. And that excitement is what leads to ongoing connectivity. So as Kristen said, in 6 months, you may have new staff. Well, it doesn't matter because you've created a culture, right? You've moved away from this implementation of software. You've moved away from the implementation of a new CANs. It's not new. What you've done is you've created a culture. And that is really what we're striving for here. And I think that's what we've been able to create over the years at Kennedy Krieger.
Well, Nate, now and here, I'll give credit where it's due. I mean, Kristen's been one heck of a champion process. And she started, when we started this process, she was the direct line clinical social worker, had a caseload. Subsequently, she's supervising, but still has a caseload. So, kind of my litmus test is if Kristen thinks it's helpful and it works, it works. And she's excited, then we're on board. And she really does have a pulse for the other clinicians, I think. So I think that has been, she deserves so much credit in terms of where we are, and where we're going. So there's still more work there. So
absolutely.
Thanks, guys.
Thank you. So that's
all right. So I guess then Mia, I guess we'll kick it back to you.
Mia, was there anything else? I know you kind of given the key word or something.